In this chapter, let's learn about medication of diabetes. In general, lifelong insulin therapy is required for persons with type 1 diabetes. It should consist of basal coverage, prandial coverage, and supplemental insulin for correction of hypoglycemia. Initial total insulin dosing ranges from 0.3 to 1 units per kilogram per day, 50% of which is basal insulin and 50% of prandial insulin. For type 2 diabetes, when the previous measures fail to normalize the serum glucose, oral hypoglycemic agents should be added to the regimen in type 2 diabetes. Treatment options in patients with type 2 diabetes should be tailored to try to target core diabetic defects and apply therapies that lower HbA1c in a weight-neutral or weight-lowering fashion if possible. Of course, cost of therapies needs to be considered as well. Next, let's take a look at the characteristics of each medication. First is metformin. The primary mechanisms of metformin is to decrease hepatic glucose production and improve insulin sensitivity. Because metformin does not produce hypoglycemia when used as a monotherapy, it is preferred initially for most patients. Metformin reduces mean HbA1c level by 1.1%. It is contraindicated in patients with severe renal insufficiency with an eGFR less than 30, heart failure, or other clinical states of hypoperfusion, and in patients with significant liver disease. Starting metformin in patients with eGFR between 30 and 45 is also not recommended. When the HbA1c level is 9% or greater, initial dual regimen or combination therapy should be considered. Clinicians should consider adding either a DPP-4 inhibitor, an SGLT2 inhibitor, a TZD, or sulfonylurea to metformin to improve glycemic control when a dual regimen is considered. Currently available insulin secretagogues all binds to the SUR1, a subunit of the ATP potassium channel on the plasma membrane of pancreatic beta cells. The SUR1 subunit regulates the activity of the channel and also binds to ATP and ADP, effectively functioning as a glucose sensor and trigger for insulin secretion. Sulfonylurea binding leads to closing of the channel, as do increases in intracellular ATP and decreases in ADP resulting from fuel metabolism. The membrane depolarization and ensues causes the opening of voltage-dependent L-type calcium channels. Subsequent calcium influx results in an increase in intracellular calcium, which leads to insulin secretion. Differences in pharmacokinetic and binding properties of the various insulin secretagogues result in the specific responses that each agent produces. The major differences among the insulin secretagogues seem to be related to duration of action and to subtle variations in hypoglycemic potential. Sulfonylureas increase insulin secretion and work best when given before meals. All sulfonylureas are contraindicated in patients who are allergic to sulfa. Use of sulfonylureas confers a greater risk of hypoglycemia than the other agents. These agents are now being considered to be used at last or later resort or when causes of a major concern for the patient, and when other therapies cannot be incorporated or contraindicated. Next, alpha-glucosidase inhibitors. acarbose and miglytol inhibit small intestinal glucose synthesis, thereby delaying carbohydrate absorption in the gut and reducing associated postprandial hyperglycemia. The major side effects of acarbose and miglytol are flatulence, diarrhea, and abdominal cramps. Next, let's take a look at TZDs. TZDs include pioglitazone and rosiglitazone. They can increase insulin sensitivity and have been used in the therapy of type 2 diabetes. Liver function should be obtained before starting therapy and monitored periodically. TZDs in general result in moderate weight gain and increase the risk for heart failure and osteoporosis fractures. Rosiglitazone has an FDA black box warning for heart failure and myocardial ischemia. Pioglitazone and rosiglitazone cause increased incidence of bladder cancer, so use TZDs with caution with fluid retention and edema. The incretin effects describes the observation that oral glucose has a greater stimulatory effects on insulin secretion than does intravenous glucose at the same circulating glucose concentration. In humans, this effect seems to be primarily mediated by GLP-1 and the GIP. GLP-1 is produced from the proglucagon gene in intestinal cells and is secreted in response to nutrients. GLP-1 stimulates insulin secretion in a glucose-dependent fashion, inhibits inappropriate hyperglucagonemia, shows gastric emptying, reduces appetite, and improves satiety, and has beta cell proliferative and anti-apoptotic and differentiation effects at least in vitro and in preclinical models. GLP-1 has a very short half-life in plasma due to amino terminal degradation by the enzyme DPP-4. A variety of pharmacologic techniques have been developed to harness the potential of GLP-1 signaling to treat diabetes, including GLP-1 receptor agonists, which are peptides that produce increases of 10-fold or higher in GLP-1 activity, and the DPP-4 inhibitors, which are small molecular inhibitors of the degradation of GLP-1 and the GIP, as well as other hormones. GLP-1 receptor agonist is usually injected subcutaneously, with exenatide injected twice a day, liraglutide injected daily, dulaglutide injected weekly, and oral semaglutide that is about to be on the market. GLP-1 receptor agonists have a reduction in postprandial and fasting glucose. In addition, GLP-1 receptor agonists can also reduce weight, improve blood lipids, and blood pressure. The most common adverse effect is nausea, which occurs in 40% to 50% of patients, usually early in the course of therapy. The nausea is mild to moderate in intensity and typically wanes over time. Nausea leads to withdrawal of therapy in about 5% of patients. It is recommended that incretin-based therapy be avoided in those with a history of pancreatitis and thyroid cancer. DPP-4 inhibitors produce approximately 2-fold increase in fasting and postprandial GLP-1 and GIP levels, with subsequent HbA1c reductions of approximately 0.7%. They are remarkably well tolerated, with an adverse effect profile similar to that of placebo. Specifically, they are not associated with nausea, probably because of the lesser increase in GLP-1 activity than with the GLP-1 receptor agonists there is no weight loss with DPP-4 inhibitors. They tend to be weight neutral. SGLT2 inhibitors are the newest class of anti-hyperglycemic medications. The kidney plays a central role in the regulation of plasma glucose, filtering at the glomerulus and resolving in the tubules approximately 180 grams of glucose per day. In the setting of diabetes, glucose reabsorption is increased as a result of increased expression and activity of SGLT2, responsible for 90% of renal tubular glucose reabsorption. There is a second active transport molecule, SGLT1, which is a low-capacity, high-affinity transporter responsible for approximately 10% of glucose reabsorption in the kidney, but critically important for glucose absorption from the gut. 3 SGLT2 inhibitors are currently clinically available, and a number are under development. Canagliflozin is a selective SGLT2 inhibitor with greater than 250-fold selectivity over SGLT1 and a half-life of about 12 hours, producing about 70 grams of glucose secretion over 24 hours. Dapagliflozin and empagliflozin are arguably more selective and perhaps have a longer half-life, though they all produce similar glucose excretion. They have been studied in type 2 diabetes as monotherapy in combination with other oral antihyperglycemic agents and with insulin. Head-to-head studies with metformin, sulfonylurea, and DPP-4 inhibitors suggest that these agents are equally effective in HbA1c reduction as the most effective oral agents. Furthermore, they are associated with moderate weight loss, 2 to 3 kg over placebo in 26-week studies, as well as blood pressure reduction. The most common side effects are related to glucosuria and include urinary frequency, genital infections, and relatively rare episodes of lower urinary tract infections, as well as dehydration and its consequences. Okay, in this chapter, we have learned medications of diabetes. Thank you very much.